I can, except I'm looking at the back of your heads. It's a little strange, but we're good.
We can both see and hear you. And we should be, we hear there's a rumor Dr. Conway will join us, and we should start in order to finish on time in the next 60 seconds or so. So I hope that's okay with you if we do that.
That's fine. Thank you.
Is it okay with you if we start on time? Okay. So 35 seconds.
And with these beeps, it is also possible, I suppose, that Patrick might join by phone. Is that right?
Logistical update for those on the phone, please. If you are calling in and you're watching the live YouTube streaming, this is the same premise as our webinar. If you could please make sure that your phone is on mute so that the sound that comes through your computer speakers doesn't feed back, that would be really appreciated. Thank you.
Okay, and is that clock pretty close to the real time?
Yes.
Okay, so we're going to start. It's 15 seconds after starting time. And welcome, everyone. I know we don't have a cast of thousands in the audience yet, but we do have Dr. Sherry Ling here in the front row next to Dennis, the agency's Deputy Chief Medical Officer. And from BC and Patrick Conway's office, we have Jean Moody-Williams. Most of you will know Jean Moody-Williams as the longstanding director of the Quality Improvement Group in CCSQ. But for those of you who haven't heard, Jean recently got a really spectacular promotion. She is now one of 2 new permanent deputy directors of the Center for Clinical Standards and Quality. And she's going to be at the president's signing of the impact legislation this afternoon. So welcome, Jean. We're glad you could fit us into your busy schedule. And
thank you. This is the highlight of my day.
Oh wow, that's amazing. And it is hard for us here. The camera's on the wall, but you're in the opposite direction, so it's hard to sort of talk directly to you. But those of you who want to talk to Jean, please look at the wall there. So we do have a packed agenda. It's a very content-rich presentation, and everyone's going to have to move very quickly and keep on time. I know that's not one of my strengths, but I pledge to finish. I've been allotted till 10 minutes after 1, and in order to set a good example, I am going to finish my segment here ahead of schedule. I'm going to try to actually cut it in half. So that should be pretty easy because I only have 2 slides. The first slide here is kind of an overview of what you're going to hear today. Jean, are you able to see the slides down there?
Yes, fine.
Okay, great. So there are 3 main points we really want to make that are the overview of the entire presentation. There's a lot more that's going to be covered, but these are the 3 main points to keep in mind. You'll recall that at our last meeting, which was May 30th, we had 3 of the 11 LEAPT topics that we deemed, based on our data and our results, were ready for national spread. And those were sepsis, C. diff, and worker safety. Worker safety has a little asterisk there, and I'll tell you about that in just 1 minute. And then we were working on trying to knock out the rest of these, 3 or 4 more by today, and then the rest of them by the end of the contract in December. And what we want to give you first is an update on sepsis, C. diff, and worker safety. And the update is really, really good. The update shows that starting from the pilot studies and the initial data that we presented here on May 30th, these topics, all 3 of them, are now spreading not just within the LEAPT HENS and the HENS hospitals that aren't in the LEAPT program, but throughout the entire Partnership for Patients 26 HEN infrastructure. We actually have a conservative estimate of the quantitative data that shows that spread, and you'll be seeing that in just a few minutes, and it's very exciting. The worker safety, we're also seeing now variation from topic to topic, and the worker safety is a little bit different, and it has aspects of it that are challenging, and the team that's presenting to you today, which come from all 6 of the LEAPT HENS, will be explaining some of the nuances there, but it is very exciting, and one of our 3 main points. 2 additional advanced practice topics, undue exposure to radiation and results beyond 40/20, have also hit what we require in the statistical analysis of outcome results in order to declare something ready for national spread. And you're going to see that data today and hear our commitment, both from CMS and the LEAPT 10 community, to begin spreading that work immediately around the 26 HENS. And then the other advanced practice topics, which are listed here in this third bullet, I think from my perspective, this is actually the most exciting part of this work. These other topics are in various stages of development and various stages of really exciting and sometimes unexpected discoveries of new learning. And what we're hearing as we spend hours with our leaders in the LEAPT HENS is that this type of work in multiple dimensions, over multiple topics and multiple timelines, has the effect of catalyzing very great action and very great work at speeds that we haven't seen before. It also leads rise. Welcome, Dr. Conway has just joined us. You can come sit here if you want, Patrick. We're just getting started, and these are our 3 learnings that I was just reviewing. And you came in at the right time, because the third bullet's actually the most exciting one to me. This has got to be one of the most exciting, cutting-edge quality improvement efforts that I've been involved with in my time here at CMS. And really, I think it derives from the fast pace that we're going and from the multiple topics that we're working on. And people are working on this as a team, and we're discovering new things as we go along. And we're also beginning to focus a lot more on the rigor of our statistical analysis. And the team is going to transmit some of the nuances of that analysis to you today in our work. You know, the early learnings from some of these interventions have revealed opportunities for other hospitals all around our network to address many topics at the same time. And Ann Hendricks in particular is going to refer to this in the work that she's doing. It's really very exciting to see the spillover effects from this work. If we go to the second slide, then there are 8. This just gives you a roadmap for this presentation. It is very content rich, and I don't want to use up any more time. There are 8 basic segments here. We're going to start with the 3 LEAP topics we did on May 30th, as I said before, C. diff, sepsis, and worker safety. We're going to cover the 3 that we had in line before: undue exposure to radiation, failure to rescue, and airway safety, and cover what the data looks like. And there are a lot of new learnings from that. And then we're going to go on to some of the surprising new things that have popped up.
I can hear a lot of.
And end with a focus on transparency, which all 6 of the LEAPT 10s are firmly committed to achieving, and they can share with you some of their successes and also some of their trials and tribulations. So without further ado, Tanya Daniels, she's the Vice President for Safety for the Minnesota Hospital Association and the Director of our Minnesota HEN. Tanya.
Dr. McGann.
Here's your clicker.
Good afternoon, everyone. It's a pleasure to be here on behalf of all the 6 LEAPT HENs. We are excited to share some spread results on the 3 topics we were here talking about in May: sepsis, C. difficile, and employee safety, in addition to 5 new topics, and patient-family engagement and transparency. And we're going to start with patient and family engagement because it is the center of our work and the foundation of all the LEAPT topics. And some early analysis shows relationship between high performers in patient-family engagement and better outcomes, such as reduced readmissions. So we know that there's more research and analysis that needs to be done in this area, but we're pretty excited about that. As a result of the LEAPT work, Minnesota has been fortunate enough to have some dedicated patient-family advisor, Lisa Juliar, to help us lead a pilot, helping hospitals engage patients and families. So we know it's not as simple. These are all examples of ways that we can engage patients and families, such as having a patient on our board, having a patient-family advisory council. But what we're learning is that it's not just as easy as that. We have to prepare the hospitals, advance the culture so that they can readily accept patients to be actively involved. So today I've asked Lisa to share her story and her journey with this pilot, and we look forward to packaging the learning and get that ready for spread in December as well.
Thank you. I'm just really grateful to be part of this meeting because I believe that the LEAPT work has been some of the most exciting changes in healthcare that I have seen. From the LEAPT platform, I have seen remarkable results. I'm thrilled to be a patient partner in developing an innovative package that's evolving from the success of our patient and family advisory, patient-family engagement, pilot that focuses on touching hearts and changing attitudes. I'm hoping that this package will create a spark and inspire hospitals to systematically and meaningfully engage patients and families at all levels of care, all the time, and embedding the patient voice into everything that they do. The foundation of this work has been the realization that patients and families need to be brought into the system as an equal part of the team in all aspects. This has been difficult for a lot of the hospitals and the healthcare workers. It's really restructuring the system to them being the experts and doing 2 and 4 patients, into patients also being experts in their care and creating healthcare together. So engaging patients and family, as Tanya said, is so much more than just having a patient advisory committee or doing bedside rounding. It's a system-wide attitude change that will result in new behaviors for medical professionals as well as patients and their families. Despite the evidence of patient-family engagement in improving outcomes, the mechanisms that translate patient and family engagement into action in the hospital are not yet fully recognized or addressed in the hospitals. So the challenge is to create a clear and compelling image of the desired attitudes and behavior changes critical to creating this new culture. If we want hospitals, from leaders to frontline staff, to transform their thinking, we need to present this image in a fresh, energizing, and out-of-the-box way. And not simply through roadmaps, toolkits, and resources, but through building the essential relationships that create respect and trust and demonstrate the mutual benefits for all of us. Restructuring the culture needs to start at the top and be supported by leaders and physicians in order for authentic partnerships to be successful and sustainable. So one of the most important lessons that I've learned through this LEAPT work and through the project I've been involved in the hospitals in Minnesota is that healthcare staff, including physicians and nurses and everybody in the hospital, are weary from the rapid changes, the intensity of the work, the increase in demands. But culturing a system that includes patients and families as part of the team can and really should be fun.
Yeah.
One hospital leader told me, "I feel like this is getting back to the reason that I went into healthcare. It's connecting with my patients and really creating health together." Hospitals certainly need the traditional tools, checklists, roadmaps, resources to direct their journey. But first, and I mean first, it is critical to capture their hearts and entice them to accept the challenge to take the patient and family engagement journey wholeheartedly. Imagine the potential for rapid, successful spread of all your learnings in these critical topics that can be life-saving. If every hospital and hospital system in the United States embraced and embedded principles of patient and family engagement.
Somebody needs to mute.
As Helen Keller says, alone we can do so little, but together we can do so much. Thank you.
Hi, Rosalie Wakeland from the Ohio HENS, and today we're going to actually, as Dr. Mann indicated, we'll be covering the 4 topics in pink, but what I'm going to start off with is give you an update on the 3 blue topics, sepsis, CDI, and worker safety. Sepsis itself has, we're seeing in all 6 HENS that are participating in sepsis an improvement and a reduction in mortality. And this is really significant because they're all starting from different points, but seeing a significant difference in all of their all the work. While all the LEAP HENS are continuing to experiment and look at different options and special populations, readmissions, as well as how it relates to failure to rescue, we're continuing to spread.
Could everybody online make sure you're on mute, please?
That we are finding, and the key lesson learned in sepsis particularly is really looking at early identification and then that early implementation of the 3-hour bundle. And so it is very, very key that we spread those. And what we're actually seeing is as we're spreading to the other hospitals, they're implementing those couple things. They are reducing mortality even faster than we anticipated. The next one is CDI. CDI also, all the HENS are reducing, showing results in C. diff. Particularly, you'll notice that Washington is a little bit below the line, and that's really due to one hospital. The other hospitals participating in C. diff in Washington are seeing dramatic reductions in results. Key learnings here that we're spreading throughout the network is really that early identification. Patients that are being admitted to the hospital with diarrhea, you need to identify them, immediately put them in isolation, not wait for results of the testing, and then also do outstanding hand hygiene. If they do that, they'll see inpatient reduction of CDI. The one key thing that we're finding is we can't stop in the four walls of the hospital. We have to go beyond the hospital and really make this a community effort, because we'll keep reintroducing into the hospital as well as into the home, and we need to continue that. With worker safety, again, we're seeing reduction here in all the HENS. Georgia, we're seeing that there is some below. They're still struggling with some of the areas of getting data from all their hospitals because of the silo system in many of the hospitals. And worker safety has always been parsed out to a different section than patient safety. And so really that integration and getting the data to show the results is where we are. Again, significant results. We're really ready to find significant areas of spread here, especially in surrounding patient violence, safe patient handling are two big areas that we're really seeing great opportunities to spread. And here, the key notes here is really to look at we're beyond the hospitals in sepsis and C. diff. The LEAPT HENS started, they're spreading it to their hospitals within the LEAPT HENS, and then we're continuing to spread to the other HENS within the network. So this represents in those two areas about 80% of the HENS have adopted those two areas, and that then in turn represents about 40% of all the hospitals are participating in the HEN project. With worker safety, again, this is representing about 30% of the HENS are now spreading worker safety, and what we're actually now hearing is many of the other HENS are doing the foundational work to begin to spread. It's just that they are not collecting the data in this area yet because of some of the data collection issues, but we're seeing great opportunity to see the spread in these two areas. With that, I'd like to hand it off to Ann Hendrick.
Thank you very much. Good afternoon, everyone. Thanks to those of you in the room and those on the phone for joining us today. As you heard Dr. McGann say, where I'd like to take you now is a little bit deeper into some of the new areas. This is undue exposure to radiation, where we believe, based on early evidence over the last 8 or 9 months or so, the results are compelling enough that we should look at this for national spread. As we all know, being exposed to radiation is not a good thing unless you absolutely have to be. And at the same time, I think there's nothing more challenging that a clinician does when they're faced with a pediatric patient or an adult, and they were well a few hours ago, and suddenly they're very sick, and they present in that way, and the difficult decision around whether or not to use a CT scan to diagnose or use something that's less invasive. So we started with a very common goal, which is to reduce the harm related to undue exposure. We have 14 pilot sites. They are very diverse sites. We have 4 at Ascension that represent both community and children's specialty hospitals with adults, and then the same within Washington State. There are 10 pilot sites there. We've been working together, really sharing our measures and metrics, and most importantly, the work that we're doing is built on a strong foundation of the subspecialty societies and organizations that have really led the evidence around this area. So it starts with a diversity of licensed professionals who work together on the care team So it's not only whether or not I use the diagnostic test, it's also how much dose radiation that the individual gets, the patient. So the RIGHT study, what we know now from working with these societies, there are screening tools that are very valid. They're considered gold standard instruments, frankly. So the D-dimer test to rule out a VTE, a pulmonary embolism, the Wells risk stratification tool. These are tools that our clinicians have adopted in an exceedingly short amount of time, along with the right order, and then tracking ourselves over time against the right dose. So in the radiation areas, often the software does not track this, surprisingly. They have kept daily logs so that they can go in and look at the doses against the age, against the weight, and against the national benchmarks. That is a key part of our work that I really want to stress to all of you. Let's now shift to the so what. What have we seen over the last 8 or 9 months? Let me clearly say that we worked against a baseline where we collected a 100% sample to say at Ascension, when you compare the diagnostic imaging against the best practice standards, how did we fare? And our baseline was the 100% sample that we then continued to track over the last 8 months. And this is with control charting. We are just one data point short of really the 8 statistical. So tremendous improvement in compliance with standards. Same thing when you look at the adult population, 39% improvement. And then when you look at Washington, this is a little bit different view. So here we're looking at the overall dose that's being given for adult head CT scan and a 7.4% reduction. And same thing again here, 11.4% reduction over time. So both ideal practices we're avoiding completely, and we're also reducing the dose for both adult and pediatrics. Here's the bottom line, the early outcome results. So 2,840 children had lower dose radiation in Washington State. At Ascension Health, we had 2,458 adults and children who did not receive, or who received rather, clinically necessary TC scans against this evidence-based practice that I just talked about. Also want to talk about what does this mean going forward, not only for our healthcare systems, but for the largest payer in the country. Based on the data that we just shared with you, we've avoided 904 total scans, 6 pediatric, 898 adults, and the radiation dose of 6,406 was avoided. If you take the national average charges reported for CT scans in just 8 months, that equals $2 million. So thanks. At this point, I'd like to introduce Lynn Hall from Georgia.
Hi, I'm Lynn Hall from Georgia, and I'm going to talk to you about failure to rescue. Failure to rescue, we just stuck the definition on here because it's the failure to rescue a patient that has a treatable condition. This is our bold aims were to decrease deaths by 10% in PSI-4, reduce the number of unplanned transfers to a higher level of care, and reduce the number of patients that had a code blue when there was not a rapid response team available. We had 2 LEAPT HENS participate with a total of 10 pilot sites. The work on this topic, we provided mentor support and monthly coaching calls and webinars. It's important that you have leadership buy-in, and it's very important to form not only a rapid response team, but to have somebody to have the hospital actually embrace and utilize the rapid response team. The most common occurrence for a failure to rescue event was sepsis related, and I think that was one of our key takeaways, was that the overlap that you had between sepsis and the failure to rescue events. We want to make sure that you standardize the rapid response team policy and protocols, make sure that the education is there not only for the rapid response teams but for the entire hospital, the entire hospital staff. We want people from environmental services to dietary to upper management to be able to feel comfortable calling a rapid response, as well as educating the patients and families, because nobody knows that patient better than the family. And then we need to analyze the data and establish mock drills and practice. Some of our rapid cycle innovations were to do rapid response team call simulations, and they identified the risk populations when they did a deeper dive into the data, and they found that the patients that had the most risk were the obese and people with significant comorbidities, like a lot of comorbidities, and then the elderly with or without comorbidities. Use of the early warning system is also very important, like the Rothman Index or the Muse, and that kind of gets you an idea of where that patient might be, and if they might need to be moved to a higher level of care before a rapid response even needs to be called. Reviewing all of the codes that you have in your hospital. And then Georgia, our hospitals are adopting a bundle, a rapid response bundle, which includes sepsis screens, blood glucoses within 5 minutes, and then they're adding a lactic acid, and they're doing test change on that now. Some of the rapid response as we were spreading through Georgia, this is our 112 Georgia hospitals. We looked at the number of events because we wanted to focus on the patients, and these are the patients. So even though this is the failure to rescue PSI-4, this is actually the number of events for the numerator from that. We have the upper and lower control limits on that, and as you can see, we're trending downward, and hopefully that trend will continue as we forecast it out for another couple of quarters. This is just a hospital in Georgia. This is Spalding Regional. They're a 130-bed acute care hospital. They were our lead hospital as far as failure to rescue, and one of the things that they noticed as just a, wow, isn't this interesting kind of moment, was the more rapid response team events that were called, they noticed there was a decrease in their mortality rate. So with further education, further study, we're going to see if this holds true in the future. The things that we think for a future objective is that, you know, we do want to spread this nationally eventually as we get things more organized and aligned. We want to encourage the use of rapid response teams by identifying those at-risk patients. We want to get the patients and family involved because patients and family know the most about their patients. And then the use of PSI-4. It's one indicator, but coupling it with mortality rate, your rapid response indicators, and patients move to a higher level of care gives you a better picture of what your rapid response team is doing with regards to failure to rescue. So if we could, you know, change PSI-4 and incorporate not just surgical patients but other patients as well, it would make it a more well-rounded measure.
Thank you, and if you don't mind, Carol, I'm going to pause here. I know Patrick has to go to a very important call here in just a minute or two. Did you want to make a few comments before you make your exit, or want to give that space?
Yeah, I apologize on the last two folks. I did read the slides. So a couple comments. One on the call, I apologize. It's a White House press call. They don't really ask about like schedules. So a couple thoughts. One, for the work that I did see, and I promise I did read the slides for the work I didn't see, just tremendous work to reflect back on a couple specific items. I think on the patient and family engagement piece, wonderful presentation, but even more so, I think the sort of, you really hit on these aspects of culture and change and real engagement as opposed to checkbox engagement or whatever sort of term you want to put forward. I think certainly I'm still learning in this arena as well, but I think I've been in organizations that try to have real patient and family engagement, and I think it does pay large dividends and really does drive a culture of improvement. Two, I think on the specific topics, everything from sepsis. I spoke at the Staunton Foundation event. Rory Staunton passed away from sepsis recently. I think major killer in the U.S. as we know, cause of morbidity and mortality. I said at this event, and you all are living this on the front lines. I still work in the hospital setting, and I almost every weekend have a resident who presents and says, this child's admitted for ruled out sepsis, and I have to say, well, actually, ruled out serious bacterial infection, because sepsis is a clinical diagnosis. If we're not looking for sepsis, we may miss sepsis. Let's talk about sort of early detection in the culture, both from electronic and scoring methodologies, plus just a culture of high reliability. On the transparency work that I was about to talk about. Tremendous work. I do think, I want to call that out because it's tremendous work, and also I think I've had to do this in a health system where there was some pushback. But I think transparency matters. We're trying to do it at a national scale, and by the way, we get some pushback too at times. But I think it's for informing consumers, but it also, which is critically important, but it also drives internal improvement. When we're transparent, we're in a learning environment, we learn from each other. So thank you for that. The couple other things that I'll be remiss, Dennis and Paul wrote me notes, but to make sure I do call out, we are. The most important thing you all can do is what you're doing, which is generating those improvements for patients. There's a sub-goal I want to call out because it will matter for us. We have a statutory legal construct that requires us to prove something worked, i.e. improved quality, and kept costs the same or lower. And this one, you all have done such a good job, and the team has done such a good job of engaging hospitals across the country. We're going to need your help on what I'll call the attribution issue. I know our team is reaching out to you. I know, because I've done improvement, I know it can seem like, oh, it's like more data collection, which is not what you want to do. You want to be doing improvement. Work with us on some of these data collection, on the evaluation aspects. I know you are, so this isn't like the team told me you weren't. It says you are. But for us internally, I think we are confident that this program is a major success, and we want to keep working with you, et cetera. But we will have to prove that to, our actuaries, Congress, independent evaluators, et cetera. So please help us in that work. And then the last thing I'll say is just what I started with. It's just tremendous work and very exciting. And I think you are spreading improvements across the nation on behalf of patients. So I want to thank you for that. And I'm sorry that I didn't hear the last two people. I promise I had it blocked. But Sherry and Jean and the team is here. So thanks a lot.
Thank you. The timing worked out very well. So we appreciate that. Jean, we'll just check in with you. As Patrick's making his exit, did you have additional comments at this time, or do you want to wait till the end?
Well, actually, I'm going to have to join this call that Patrick's on, but I echo all of his comments, and I think there were a couple of many key things, but two I want to just point out is one where you said that you really have to go beyond the walls of the hospital, and in particular you were talking about C. diff, but that is just really true with most of the topics that you all are working on in order for us to be impactful and effective. So I just want to thank you for the collaborative efforts that you've taken thus far, and encourage you to continue to look in that medical neighborhood that you're working with. And the other thing that was remarkable to me in the presentations, particularly the ones on lowering the radiation dose and the CT scans, is that when we talk about improvement, lower cost through improvement, this is exactly what we're getting at. No, not just striking the bottom line, but looking at the services that are provided and how when we reduce waste and we improve safety, then we get lower cost through improvement. So just great work, and I'm encouraged and can't wait to come out and do some more visits.
Thank you, Jean. So, Dr. Ling, you're able to stay until the very end. So we can pass it back.
Well, thanks so much. The next topic we're going to go through is airway safety. I'm Carol Wagner. I'm the Senior Vice President of the Washington State Hospital Association. And I just really wanted to thank CMS for your support, for the innovation, but also for the accountability that is really helping advance movements forward. Our hospitals call this extremely grueling work, but also some of the best work that we've ever done. When you think about airway safety, there's really two different parts of it. One is trying to prevent issues with the airway up front, and second, when you do need to manage the airway, managing it very successfully. We are the only HEN to pick airway safety, and we have approached a lot of our work in terms of how do we intervene to not need airway management. We are now working on the management of the airway to make sure that that is effective. The partners have been very, very helpful and very much on board, the professional societies, and our experts have been great, and Dr. Rothfield is in essence just such a champion and helpful in this area. There's several strategies that we put into place to help with airway safety. The first thing is that we looked to find what were those issues that were causing airway safety problems. Sleep apnea was a huge concern for us. It wasn't minor issues that were being caused by sleep apnea. Patients were dying because of sleep apnea. And we're finding through the literature that more and more people have sleep apnea. We put into place a screening tool called Stop Bang, where we are screening for patients that have apnea and then marrying that with internal processes that nurses and respiratory therapists can use to take action based upon those scores. We've also done a lot of work in that as nurses and respiratory therapists tried to take action, the next step was, well, they didn't have the airway cart that they needed, or it wasn't the right equipment, or it wasn't standardized. So we worked through those processes also. Another piece that was extremely important was having standardized order sets around this, and also making sure that when we have to intubate, we're using tools that make sense in today's environment. The original laryngoscope was developed back in the 1940s. It's kind of like a flashlight and a shoehorn. And if you look at your neck, it is not the shape of a flat shoehorn. So we put patients in incredibly difficult positions, and then we force it down their throat. And what some of the research by Dr. Rothfield has found is that by using video laryngoscope, which is better shaped and also has a video monitor, we can very quickly, safely, and with much less injury intubate people or maintain their airway in ways that we couldn't do before. Here's some of our airway safety results. This is the trend line that we've had for monitoring our sleep apnea. In our original proposal, we talked about doing this in ICU. Our hospital said patients come in with sleep apnea everywhere across the hospital, so we are doing this everywhere. And it is really important screening, and then we have the guidelines to go along with that. Dr. Rothfield's research shows that by using the video laryngoscope, 90% of initial intubations can be successful using the original laryngoscopes, or 50% are successful. Also with the video laryngoscope, there's only 1% problems with having injuries, and most of those are bruised lips or things like that. My one ask around this topic is that we are very interested in working with the Joint Commission to do a safety alert around this topic, and we would love to partner with CMS in working with Dr. Chasson to get that safety alert in place.
Very good. So hi, I'm Jason Bourbon with Carolina's Healthcare System, and I have the privilege of discussing our Advanced Illness Management program through LEAPT. It is part of what we're describing, the category for LEAPT was HACT results beyond 40/20, and Advanced Illness Management here you can see is one critical, but only 1/4 of our broader LEAPT project. I could talk all day about this project, but we're trying to reduce readmissions, focusing on SNFs and what are the drivers for readmissions from that particular population, as well as home health. And then another component is trying to increase education, advanced care planning, and ultimately hospice services by minority populations, which are traditionally underserved. But my focus today will be advanced illness management. And what we describe as advanced illness management is trying to tackle a very interesting vulnerable population. We're looking at patients that have chronic conditions. Most of them have multiple chronic conditions. Polypharmacy issues are rapid. And really, the way we describe them is folks that are vulnerable to falling through the cracks of the broader healthcare system. So these folks often don't have family or friend social structures built in at home. There's often transportation issues. There are often many biopsychosocial issues. That's who we're really trying to tackle. And the ultimate goal is, you can see our LEAPT bold aim is to achieve a 50% reduction, not in readmissions, but in total utilization. We're looking at ED visits and and hospitalizations, period. And so the idea is taking this very challenging population and trying to develop a real comprehensive plan of care. We talk about that it is trying to care for the whole patient, not trying to treat a condition. It has a lot of components to it, and ultimately we want them to get at the appropriate level of care. So we're not being a barrier to them coming back to the hospital. In fact, we've often talked to our patients that go to the ED now, but it's trying to get them to the appropriate level of care based on their condition. And so this is just a wonderful, hopefully graphic that describes, again, the wraparound services, multidisciplinary team. I will focus here on the purple box, which is the LPNs, and they're really the front line when it comes to these staff, or to these patients. These patients have they know them by name, they have contact information, can talk to them 24/7, and they're where the implementation of a care plan exists. This is Gwen here in the middle. Gwen is an actual patient in our AIM team, and it's given us privilege or the rights to share her wonderful picture here. But the idea here, again, you can see is we've got a multidisciplinary team, and we can tap into other folks, pharmacy, dietitians, et cetera, to make sure we're getting the appropriate care to the patient based on their particular needs. I'm very excited to say, again, a 50% bold aim. This is our biggest bold aim in LEAPT. And here is how we sort of tackle that data. This is different for us. It's not a hospital-specific measure. It is a patient-specific measure. So if you look at this, hopefully it's purple on your screen. But the top graph here is showing utilization for this particular population the 6 months prior to them coming into the program. And then the green is the 6 months post them coming out of or going through this program. So you can see a 67% reduction in utilization over time. This is 25 patients. If we expand to 81 patients as we continue to enroll, still meeting numbers here. Bottom line, 64% reduction in utilization overall. So the continuation is going. And then bottom line here is we're trying to get an estimate on the cost savings, looking at ED costs, hospital costs, observation unit costs. And right now we're estimating that with these reductions of those 81 patients thus far, it's saving $872,000. When we look at our payer mix, based on the patient population, we're estimating that that's about $580,000 that comes back to the government itself. So very excited about this program. That helps.
This is a second sample of some of the work that we're doing in taking the concepts that we worked on in the 10 hats and really expanding it. After the early elective deliveries, our obstetricians and hospitals and folks in the medical clinics were so excited that we started what was called the Safe Delivery Roadmap and put together a coalition of government, March of Dimes, professional societies. Of course, medical society is at our side as we go through. The purpose of the Safe Deliveries Roadmap is to put the evidence around the entire continuum of care for OB patients, from pre-pregnancy, pregnancy, delivery, and first month. And our Department of Health is working with us. We're even doing one step before that now as we move forward. This is really important because early elective deliveries, although very valuable to patients, is just one small piece of this. And this is the first time I think we've ever tried to take all of the evidence at once, put it in place for a population as we move forward. We've designed what that care will look like across each of those pieces, tied it to literature, and we've implemented the delivery bundle in our LEAPT hospitals and are now rolling that out to all of the other hospitals that have obstetrical services in our state. This is an example of what those best practices look like. It is from the literature, but it is also from emerging practices. And the wonderful thing is that the literature continues to grow and continues to get more rigorous. But we've also learned through this process is why it takes 16 years to get the medical evidence in place. And it is because there's the medical evidence, but it doesn't tell you who are the inclusions, who are the exclusions, how do you measure it, how do you make sure that you're safe with it. So we have a number of balancing measures that we're using, such as neonatal complications, to make sure that as we do this, we are keeping mothers and babies safe, which is the purpose behind this.
I lost my internet. Hold on 1 second. Okay.
So we have approximately 100 physicians actually engaged in this process in various teams that are going forward. We've developed a ton of resources around these, and the process that we use to do this is the rapid cycle improvement. And we found that many of the strategies that we thought were wonderful at the beginning, when we actually tried them in real life, turned out that they needed some revisions. What we found is that we have now a 31% reduction in inductions with unfavorable cervix per delivery. We also have had 113 fewer deliveries with unfavorable cervix as we go forward. In our next report that goes in this month, we have 178, so the results just continue to get better and better as we move forward. Better care for mother and baby. I want to take us back just for a minute to just share a little bit about how this really works. You know, we may be working on a measure such as early elective deliveries. This work in partnership for patients is sustaining. The folks have bought into it. It is so important as we move forward. But there's also other outcomes that we're beginning to be able to measure and see. If you look over here on this graph, our work began in Q4 2010. This is information from our Department of Health, and our cesarean section rate, no matter whether you do NTSV or you're looking at the primary C-section rate, was rising, rising, rising. And lo and behold, when you get to 2011, that is when our trend begins to go down. Now, we don't have enough points to know for sure if it's a trend, but the direction is certainly interesting. So as we measure one thing, the benefits to patients on many levels is very, very positive as we go forward. But it's not just enough to share this information with hospitals and to move this forward. We have information that we need to be sharing with the public, and we have accountability. And all of us as HENS are working and in action to ensure that we're transparent in sharing our LEAPT data and results across the systems. This is a website that the Washington put together back in 2008. There weren't as many measures when we put it together, but as you look at it now, there are so many measures that, although it's still helpful, it takes a lot of work on behalf of the public to go through and figure out what any of these mean. This is the website that is now open as of September 30th for hospitals to review, and it will be open to the public on October 15th. If anybody wants to send me a flak jacket on that date, I would be more than welcome on that. This was designed by patients advocates, and also by doing focus groups with elected officials in terms of what do they need. Very easy to use. The next section is really just icons that folks can pick, and then the bottom is a map of the state where you can pick a hospital. This is what the icons look like. They were designed by patients and families. We began to already populate many measures, both from the 10 hacks and also from LEAPT measures as we move forward. This is what, if you were going to drill down into an actual hospital, you can compare hospitals, you can sort by geographic area, by zip code, making it easy. We also have tips, though, that are specifically designed by category. So these tips about babies being better if they're carried to term is because this is a mother and baby slide. And one of the new innovations that we want in our next generation is to take the lowest scores of the hospitals and have the tips come up so that the patients will actually go to their care providers and ask questions about this. So we have to figure out how to program that, but that's our goal of what we want to evolve to. This is what we have also done, Safe Delivery Roadmap, continue to populate more and more. And this is our thermometer from the focus groups. Some of the people liked numbers. The other people like to have really thermometers that had easy to see, okay, who's doing better. There's also graphs if you want to see all the data for this hospital, if you want to do comparison between hospitals, or just want a table like we had before. This is an example of what, if you have more graphs across what it might look like or compare between various hospitals. So in summary from our point, and then Paul's going to come up and say a few more summary points. We just really wanted to thank you. Partnership for Patients has been immense value. Even with all of the hard work, with the rule of what we've been doing, our hospitals are excited and dedicated to continuing in this work and this effort. All of us as HENS have Partnership for Patients or terms similar to that, at least the actions around Partnership for Patients as part of the strategic plan. This is the Washington State Hospital Association strategic plan for 2015. And the very first item that our members put on that strategic plan was to continue in this work and to continue the benefits as we move forward. That would only be there if they were finding such value for their patients, for their community, and for their staff as we move forward. So with that, Paul, I'll let you finish.
Great. Well, why don't we give our presenters just a round of applause. Not only an on-time performance, but a performance 2 minutes early with some discussion with Dr. Conway and Jean Marie Williams. So really spectacular. I have to say, honestly, at 8 o'clock this morning, I wasn't quite sure we were all going to be able to do it, and we pulled it off. So thank you very much for that. Sherry, we're just back to where we started. I think you're the only person left, at least in the visible audience. These are the points that we started with. So just to recap, you recall on the May 30th meeting, we had sepsis, C. diff, and worker safety. And we also continue to track results and show them on our plots. But more than that, we're now quantifying the spread, not just through the LEAPT HENS, the 6 LEAPT HENS, but all of their 20 colleagues as well throughout the country. And we're starting to see differentiation. Some topics turn out to be easier to spread, and there's more consensus, I think, in the country, like sepsis, to get it everywhere in every hospital. Other topics, like worker safety, we're running into a little bit of resistance and difficulties in some areas, and we're starting to ask questions and understand that. For the middle topics, I hope you agree with us that the data really do, I think it's very exciting when Ann presented about undue exposure to radiation. I mean, this is just, and Jean confirmed that, this is right over the plate in terms of what we want to do with quality improvement. It decreases exposure to radiation, it is coupled with decreased utilization of unnecessary tests, and it improves quality. So that's right over the plate. These exciting topics that Carol Wagner and Jason Bird presented with the advanced illness management and the roadmap to safe deliveries, they're kind of things, Sherry, that in this very fertile ground and rapid cycle pressure to produce results pop up, and we couldn't have predicted them on May 30th, but here they are, and the results are emerging, and we thought we would present them here. Some of these other topics that we originally had intended and wanted to be putting forward, failure to rescue, airway safety are 2 of them. A lot of work's been done, a lot of learning is coming out, but we are taking the requests that we're getting from many quarters now to analyze our data seriously and rigorously, and to not do premature pronouncements that something is finished quite seriously. And we think even within that, this rapid cycle learning is something that this particular community has become very adept at, and we think working with each other in this way keeps us honest about the results and keeps us always struggling to get the highest quality data coming in. As you've seen in some of the just more recent presentations toward the end, some of these iterations actually lead us to question the measures and question if there's something that could be improved by the measures. So there's a quality improvement QIMHOG cycle, if you know what I'm referring to here as well, which we think is also helpful. And probably one of the most moving points when we had our pre-meeting here this morning that Carol Wagner brought out and just made was that statement that she had just a couple of slides ago, maybe I'll even bring it back up again, that when you work with a state hospital association and you start impressing with the value that you're generating, it actually is a positive feedback loop and recycles back to the strategic priorities, so that in the state of Washington, achievements of both base HEN and LEAPT HEN start to become a shared priority and goal throughout the whole state with all the providers in the hospital association. And that's a very powerful observation. Carol pointed out to us again this morning. So I think I'll stop it there. We're right on time for 10 minutes of discussion. And
sure, if I could just share a couple of thoughts. First of all, just to say thank you. I'm completely blown away, in a good way, by the power of the activities, of the data, of the commitment, of the energy. Really impressive and greatly appreciated on behalf of our beneficiaries, patients and families. I do think that This is exactly over home plate, as you will, or between the, whatever those things are. Goalposts. Or right in the right channel to catch that wave. Because these are also HHS priorities. In that this is about complex populations, persons with multiple chronic conditions. It is about protecting and preventing harm in this very vulnerable and growing population. It is also about reducing and mitigating the consequences of infections that would otherwise go untended and a leading cause of death and morbidity, which is sepsis. But at the same time, the balance of C. diff being that is overtreatment, right? So you've got balance implicit in this work, which is absolutely tremendous, and that is beyond HHS, completely in line and with the national security and White House announcement for combating antimicrobial resistance. So, very much aligned with that. I agree. There is definitely information we can share and we can build in the direction beyond what is happening in hospitals and patient cares. This is about measurement as well. So the work in reducing radiation, undue radiation exposure is about overuse. It's also perhaps about appropriate use. And building in the patient theme about involving me in my own care. If you back up like a imaging study, wouldn't it be nice to know how will my care team use that information that's obtained from this test, right? To guide my care. So it actually is an opportunity to further weave in, I think, decision making, patient care goals, and to be able to really meet on spot what those care goals are. So, again, involving patients and families in their care. And the final point being that this is about data, it's about care planning and predictive modeling of future events that have yet to play out, if you will. This is very well aligned in being able to predict health versus disease and using the clinical data in a very unusual way to anticipate before things go bad. So, really compliments to you on this. And I will end by saying this is not your grandmother's research project. This is this is not a science fair project, right? This is real-time data that we are using to improve care out there, and thank you for that, because this is really disruptive in the sense that waiting for data to come in, a randomized trial that is measured perhaps differently at a different pace, and this is why I'm here at CMS. So thank you.
And this would have had to have been 11 separate randomized trials.
Oh my goodness, absolutely.
It's that interaction and synergy that's also really
absolutely.
Big thing. There's one other thing that's very timely here, Sherry, I wonder if you wouldn't mind commenting on. And I riffed this off Jason Bird's presentation, which is one of these things that popped up that was unexpected, and that's this advanced illness management. And you remember how when he showed the measures, he had population-based measures, not just of readmission, but of hospital and ED utilization, how he was tracking an entire population of patients over a short period of time, simultaneously tracking cost savings. But what made me think of it with the impact legislation, and several other presenters said this as well, is they're going as a hospital system outside the hospital and into the community, and they're starting to interact with other levels of care, such as home health, long-term care, skilled nursing facility, and so on. And you might just want to mention just 30 seconds on the impact legislation the president's going to sign probably in a few minutes, and how it sort of relates to their work in that.
Right. So it actually does relate. Right now, it's an indirect relationship, though, and the Impact Act is basically improving Medicare post-acute care. right? So what it does is it's an opportunity and requirement for us to standardize data across care settings, across post-acute settings. But implicit in that is achieving what has been difficult using these individual siloed legacy tools, which is, measurement of things that are important to patients like function, symptom severity. All patients have in common their desire to be pain-free, be able to breathe comfortably, and to be able to do what they need to do to be people, not just patients. So that is kind of all rolled into the impact legislation. It is about measurement. It's also about the opportunity to communicate and coordinate across care settings. So this is on the impact legislation is a timeline with a figure that includes hospital standardization of some of these important areas as well. And I think your work really is in the spirit of how do you improve for on the behalf of patients and families, and do so as a system that goes beyond the walls of any bricks and mortar of a building. And so that's something that, thank you for asking about that.
Yeah, I see the connections right
Yeah,
there.
the connections are there. And
so I see we're about 1 minute before 2. We're actually able to stay. I don't know if you are or not, if you have other things, but maybe I'll just ask Dennis if he had any closing comments, and then we're able to have a discussion further.
Yeah, I think this isn't really a closing comment, but I do want to check in. I know that we have had a number of people call in who have been online. And I think it's possible, I'm going to check and see if Chisara Asamugo might be online. Chisara is a senior advisor to Dr. Conway, and together with Sherry Ling and Jean Moody-Williams, and Debbie Hattery is in the front office. So I'm just going to check. Chisara, are you there? First of all, are you there? Let's just try that. Okay, I'm going to take that as a no. I don't think
And we
have
know
Chisara.
Debbie Hattery's in France on annual leave, so
yep. So
very
we're
unlikely she's on.
Yeah. Part of the reason I was checking with Chisara is she just popped me an email about your presentation and was loving the things that you had to say. So I wanted to make sure we had the space if she wanted to comment that she could do so. I think you see, Sherry, I think maybe the one observation I'd make here is that we've got a genuine community of practice that's working, I think, in innovative, out-front ways, doing extraordinary work, but we're doing it together. I mean, you saw here hospital engagement networks that are presenting the work of other hospital engagement networks, on these shared aims and shared purposes that we have. And I just think it's not difficult. And as kind of one additional point on that I'll make is, I know you were heavily involved in the grand round session that we had on airway safety, for instance. And Dr. Kenneth Rothfield with Ascension.
I'm on the phone.
So let me finish this sentence. Thank you, Chisara. We'd love to have your comments on this. But Dr. Rothfield, profiled the extensive work that he's done in his hospital. And Carol Wagner, our one hospital engagement network that's working on airway safety, said, I'm going to pick that up and I'm going to take it and I'm going to run with it across the state of Washington. And that's just, this isn't typical kind of behavior. You know what I'm saying? This is an extraordinary community of practice that we've got here, and it's a delight for us to work with them. I think they're doing great work. So let me just check in then. Chisara, is that you? We'd love to hear any comments that you might like to share with the group if you're with us.
Yeah, just real quickly, because I don't want to keep you guys over, but I am just thoroughly impressed. I'm the Senior Technical Advisor in the Center for Clinical Standards and Quality and a pediatrician by training, and just thoroughly impressed by this work. I was telling Dennis via email that if we could do this even more, to share this reassuring information and progress. And I stress on the word reassuring, especially with a lot of the messages that we get in the media about what our healthcare system is doing, and all the feedback that we're getting from different organizations. This work absolutely demonstrates how important it is not only for the resources to be placed right in the setting for the patients and for the facilities that are providing the care, but also for the entire system as a whole in just terms of transformation. So I just want to say thank you and how excited I am and so pleased and very proud to be part of a group that is doing this work on behalf of beneficiaries everywhere.
Great, thank you, Dr. Matsumoto. We're glad that you could join us. Keep going. Others? Questions, comments?
I mean, it's pretty informal by this point, so I know you all think about CMS a lot, and I know we've been sitting here for now, how long have we been sitting here for? I can't remember, but it's like 4 or 5 hours.
Or 10, yeah, something like that.
And you must have thoughts about CMS and CMS's contribution. We've heard that you appreciate this project like that, so we get that part. But are there other concerns? I brought up the Impact Act, in part because there's this interesting synergy, dare I use the word, between Congress and CMS in terms of how these things get rolled out on a national scale. It's certainly the case that Congress passes laws and we implement a lot of them in different ways. But do you have observations or thoughts for the next 12, 24, 48 months in terms of that relationship or things that impact you and your hospitals and your patients? Things that you're thinking about or even concerned about?
Seeing what the Impact Act looks like, I think there's a lot of alignment with some of the lead topics that definitely could use the standardization and going across the settings of care. So I hope that there's some way to continue to spread this work that's just starting and the excitement that's across our networks and in the hospitals.
But not only the lead topics, but in addition to the foundational, I think that the whole idea of patient care is finally turning back to the way it should be. It's focusing on the patient, and I mean, I think Jason's project on AIM is just a perfect illustration of the way healthcare should be.
And if I can make one point about that, and this is not a reflection on CMS at all, but yeah, I mean, I think that we are bringing to life, because it's a smaller cohort, I can talk about just about every patient and who are all very different, and it is getting back to what we're supposed to be doing. One thing I will say is we've had to ratchet back our original plan, and that's because as we started talking to council and they started talking to us about the Stark Law, and that if we went out and provided free services to folks and if they went and said that this is wow, the system's really doing this great thing, and then promotes it to someone else, they come and use us, that we could get in a lot of federal trouble. And so I think we're meeting the spirit of what the Affordable Care Act is trying to get at, but there's this interesting chassis that it's built upon that is kind of holding us back, and for good reason. I mean, I think, but it is interesting that we've had to maybe do a soft version of what we really wanted to do.
And just to connect the dots, further, and this is something that we haven't been able to measure, but we know clinically happens, right? And the implications of all that you are doing is that by mitigating, sepsis early and rescuing in the hospital, you actually, if you're prompt in your treatment, you'll be able to preserve your function, not only live and not die, but actually live after you are discharged from the hospital, which then ties in your ability to preserve function, because there's less of this drawn out course of illness because things weren't detected early or you didn't anticipate the problems. So on the back end, that is an important aspect, I think, but we have not been able to connect the dots yet. It's there.
We had a great session on Friday. I think you knew that we were going down to NQF for a session on patient family engagement that involved a lot of patients and a number of the people in the room. Jason presented, Carol was there with one of your outstanding teams from Everett, Washington, and Chris Castle kicked it off. And she made this point about she was recently hospitalized, and this kind of comes back to what Rosalie was saying a few moments ago about returning the patient. She said she observed that particularly the nursing staff spent like 90% or more of their time with the checklists and the protocols and what's your name, what's your identification. Right. And she was reflecting on the standardization and the focus on procedure, process, and good standards of care has kind of depersonalized the experience, and she was talking about bringing the caring back in. And I think that's a big part of what we're learning here on this patient-family engagement. I mean, you heard it, firsthand from our patient representative and from Tanya in Minnesota, but it really, I think that we're onto something really, really important here in terms of bringing that back.
Absolutely. There was a paper, a perspective piece in JAMA, I think, of all journals, and it's about the convergence between evidence-based and engaging patients and families in conversations. So there's the tools and there's the data, but it's also about having conversations. And that's one thought I had for maybe Dennis and Paul, as we go forward, since we're really trying to do this as a system. Our partners at HRSA, who are involved in workforce development and pipeline, it would actually make sense if we had a workforce that comes in to the game as they're training and acquiring the skills, not just about the tools, but remembering how to have these conversations. I think that's really important. And as a geriatrician, people are like, oh, what do geriatricians do? I said, we talk to our patients. we want to
And there are other providers too.
And there are other providers. We're the glue. You never know us until we disappear, and then. But anyway, so that's something to think about, because I think this would really be very powerful to build into the makings of our pipeline.
Yeah.
For future generations.
Yeah, that's exciting.
But thank you. I whispered to Dennis, Grandma's 2015.
Yes, Lisa.
So I agree with you wholeheartedly, and I feel like if there were more relationship building things, teachings and trainings, the checklists and all those things wouldn't be as necessary, because they would be learning as they go. And I appreciate you saying that, because that's what I have found in this last year, is that people, even in the hospital, want to get back to that relationship piece, and they're really overburdened with all of the checklists and tools that they have to go through in order to get to the patient.
I think it's both, right? I mean,
exactly.
We use the tools, but know their tools.
Yeah.
It's not the complete. Tools. Yeah, they're tools. It's your tool, powerful tool, but it is a tool. So thank you.
Sorry for
coming.
Very good.
Yeah.
Thanks for coming. Appreciate it. Yeah. Thanks.
Thank you all. Great job.
Very good.
Thumbs up.
That's easy enough.
Okay, thanks, Sherry.
Thank you, Dr. Lynn.
I also check in on the phone. I know the CDC was sending a couple of representatives. Arjun or anyone there, did you want to make any comments? I know Shelley's the project officer for their contract. I know that they had said they were going to attend. So if they have any questions, I'll be sure to follow up.
And if they're online, on the YouTube streaming, there's a few minutes delay. Okay. They might have to jump over.
Gotcha.
Oh, really? There's a delay?
Yes.
Yeah, Caesar is reporting a delay measured in minutes.
Yes.
Between what we said here and when she,
Oh, no.
which explains why it took so long.
Yeah,
I thought she was just having a hard time getting off muters.
I see. I'm glad she jumped back on, or she stuck with it. Yeah.
So are we in formal debrief mode?
I
Or?
think so, yes. Is the streaming included, or do we have to stop?
No, I'm not going to stop it right now.
Okay, well, thanks, everyone. If you can hear us 15 minutes from now, for joining our little session. This ends the formal session, and we'll be winding down here shortly, but thank you for joining.
So in terms of debrief,
Thanks very much.
did you have any questions that we should run
We
or
did,
anything
yes.
along those lines?
Our usual three, what
Yeah.
worked, what would you do more of, better, different?
Yeah.
Can I ask you a question? It was clear that folks enjoyed this. Is that pretty typical, or just kind of trying to measure where this is at?
I'd say nothing about this is typical in terms of how these kinds of things happen. At least in my experience, I think it's very common. Come together.